Good evening, everyone, and welcome to our last BOMSS Journal Club of the year. I'm delighted this evening to be joined by the team from Southampton and with our host, Mr. Jamie Kelly, with a whole host of exciting news on endoscopic bariatric procedures for you. Before we start, I'd just like to run through in terms of our future upcoming BOMSS programme. Please remember that we've got the educational webinar being brought forward next week to the 14th of December so that it doesn't clash with Christmas. And that's going to be hosted by Professor Silvana Peretta, who's going to be talking about endoscopic outlet reduction for weight regain and dumping syndrome. So please do join us next Wednesday evening too. And then the following journal club on the 11th of January in the new year will be hosted by the East Midlands Bariatric Institute. Thank you to Amy Ride, who's my co-chair this evening, and Mr. Kelly, who's going to introduce the team and take it from here. Thank you very much.
Great. Right. I'll just bring up some slides and then we will get going. Righty-ho. Let's just, there we go. Right. Evening, everybody. Hello from Southampton, as it were. And thanks to my colleagues Chen and Zach for helping out this evening. But as just a little bit of an introduction, I think I'd just go and explain ESG a little bit, as it is an evolving technique, and we must bear that in mind when we're looking at the literature. So it was first reported in 2013, and now there's about 40,000 cases done worldwide and over 200 sort of peer review articles available. But it's early. And if I sort of go back to when I was appointed 14 years ago or so, in 2008, this was the big paper of that year about sleeve gastrectomies. It was the big review article, and if you can see, there were 3 retrospective studies there, relatively small numbers, 1 prospective, again small numbers, and only 1 randomized trial. And so a lot has happened with the sleeve gastrectomy in the following years. And that's really the sort of stage we're at with the ESG, evolving evidence. The other thing that we're often compared to is the laparoscopic gastric plication, which is a sort of obsolete operation really now, is it has a higher complication rate and a poorer weight loss than a sleeve gastrectomy. But, you know, again, it's a slight unfair comparison because it doesn't work in the same way. You know, traditionally the more surgical, the resectional operations, you know, see gut hormonal changes which lead to you know, sensation of loss of appetite and fullness, and that's led to the medical pharmaceutical developments that we're seeing coming through shortly. But with the ESG, we're not taking anything away, so we don't see the hormonal changes that we see with more formal surgery. And this is what an ESG sort of tends to look like at the end of the procedure. There's the pylorus coming back through the antrum, and then the first stitch, and then we see the lumen narrowed and the length of the stomach shortened. And importantly, we're not taking anything away, and importantly, we are leaving a pouch just off to in the fundus there, off to the left. A little difficult to see in this example, but believe me, it's there. Now, why that's relevant is how this works, and the food goes down the esophagus into that fundal pouch. You get distension in the fundus, it fires off the stretch receptors, the patients feel full, and they use that sensation of fullness to portion control. And if you try and replicate other operations, if you try and produce the sleeve or the laparoscopic plication of the stomach with the ESG, we'll see that actually you get less weight loss. Okay, so it's very important that fundal pouch is maintained to optimize the procedure, so it doesn't work like other operations. And the Mayo Clinic have also demonstrated that rather than increase gastric emptying, like the sleeve does, it actually reduces gastric emptying. You get delayed gastric emptying with this procedure. So it's a different operation, and we're comparing it a little bit apples and pears, but it is important, and we're still in an early phase. And so when we're looking at the data, we need to appreciate that. And anyway, I will now, having given that introduction, I will hand over to my colleague Chen, who will discuss the first paper.
Thank you, Mr. Kelly. So good evening. First of all, I have to apologize. I don't have a camera because I'm on a work computer, but my name is Chen Ji. I'm a ST5 Upper GI Registrar at Southampton, and I will be presenting these two papers that we are discussing today. So without further ado, we will start with paper 1. So paper 1 is titled Comparative Effectiveness and Safety Between Endoscopic Sleeve Gastroplasty and Laparoscopic Sleeve Gastrectomy, a meta-analysis of 6,775 individuals with obesity. So this is a paper that was published by Barron et al. From the Mayo Clinic in August of this year in obesity surgery, which has an impact factor of 3.346. Sorry, just trying to move on to the next slide. So this is a systematic review and meta-analysis looking at the effectiveness and safety when comparing ESG versus LSG. And the study is looking at primary outcomes of total body weight loss percentage, excess weight loss percentage, and overall adverse event rate, and also looking at secondary outcomes of improvement of comorbidities, specifically looking at diabetes and hypertension and incidence of new onset GORD, which we know can be a problem with sleeve gastrectomies. So just moving on to the next slide. So in terms of data collection, the authors looked at all published studies from inception up until March 2022 and included these search terms. They included all languages, and the specific outcomes that they were looking at were total body weight loss percentage, excess weight loss percentage, and adverse events. So they utilized PRISMA guidelines. They initially identified 573 studies. After screening and assessment for eligibility, they all but 7 of those studies were excluded. And of the 7 that were included, these were observational cohort studies, and these papers were published between 2018 and 2022. This included a pool of 6,775 patients, and it is important to note here that 6,036 of these, so 89%, came from one large study carried out by Al-Khatani et al., which was published in Gastrointestinal Endoscopy in March of this year. So in terms of patient demographics, 87% were female. The patients had a mean baseline BMI of 33.7, which I think we can agree is lower than expected than for the UK population, and follow-up periods ranged from 6 to 36 months. So in terms of the results of their primary outcomes, so as we can see, there was substantial weight loss seen in both LSG and ESG groups at all time points, so 6 months and 12 months. However, there was a statistically significant difference in favor of LSG. Of note here, the American Society of Gastrointestinal Endoscopy states that for an intervention to be beneficial, a weight loss of greater than 25% of excess weight loss percentage is required. And as we can see, ESG is massively in excess of that. This slide also just shows the total body weight loss percentage, which shows the exact same trend of weight loss, significant weight loss at all time points. However, it is also statistically significant in favor of LSG. So looking at adverse events, there was a lower incidence of adverse outcomes in the ESG group when compared to the LSG group. However, this did not reach statistical significance. The authors then went on to do a sensitivity analysis by excluding each study in turn to assess for its effect on overall outcomes. And they found that by excluding the Al-Qahtani study, there was then significantly fewer adverse outcomes in favor of ESG, with the adverse event rate being 2.5 for ESG when compared with 12.2% for LSG. And the author remarks that this is possibly because in the Al-Qahtani study, they only looked at adverse events for the first 30 days post-procedure. And as we know, late complications with sleeve gastrectomies are not uncommon. So in terms of looking at secondary outcomes, for diabetes, there was a significant improvement in diabetes that favored the LSG group. There was no difference seen between LSG and the ASG group for hypertension. However, importantly, they did show that there was a significantly lower incidence of new onset GORD in the ESG group when compared to the LSG group. So from the authors in the study, the take-home message that they wanted to convey was that total body weight loss percentage is in favor of LSG. However, there was a trend towards lower adverse event rates in the ESG group, which was statistically significant if you excluded the Al-Qahtani study. And in terms of impact on comorbidities, there was, in terms of diabetes, there was a greater improvement in the LSG group. There was similar for hypertension in between the two groups. And in terms of onset of GORD, this favored the ESG group. So the strengths of this study. So they had clearly indicated their primary and secondary outcome measures, and these outcomes were also clinically important. They implemented PRISMA guidelines. They had a clear methodology. They only included studies that had direct comparisons between ESG and LSG, so they didn't include any single-arm studies. They had a clear discussion and they were very clear in their assessment of the limitations of their own study. And actually currently there's very limited evidence directly comparing these two. So it was a very interesting paper. In terms of weaknesses, the studies that they included were all observational and 5 out of 7 of the studies were retrospective. There were no randomized controlled trials included. Despite the authors using a random effects model, there was still significant heterogeneity in terms of patient characteristics, operator technique, lifestyle interventions. And as we touched upon before, 89% of the patients included in the meta-analysis come from one study, the Al-Qahtani study. And they drew most of their conclusions from this study, in fact. However, when it came to looking at adverse outcomes, they excluded the study in order to prove the point that they wanted to convey. In the Al-Qahtani study itself, they had a lower baseline BMI, so their average BMI was around 30, which is a much lower BMI than what we would see in the UK. So it begs the question as to whether it's applicable to our population. And in a similar vein to this, there were no UK-based studies included in this meta-analysis. There was only a limited follow-up, so only one study had follow-up of greater than 24 months. And the authors were unable to analyze publication bias assessment due to a small number of included studies. So just summarizing now the paper. I think it was a good attempt at assessing the evidence comparing LSG and ESG. The primary outcome of weight loss is more effective with sleeve gastrectomies. However, ESG does achieve clinically meaningful weight loss, and it looks like there's a trend of ESG towards lower adverse outcomes in terms of both complications and in terms of the onset of GORD. So it's not a perfect study, and it does have sort of methodological issues with its methodology, and the entire meta-analysis is highly dependent on the Al-Qahtani study. And as with a lot of these papers, longer term follow-up is required, and we need more randomized controlled trials. And that is the first paper.
Fabulous, thank you. That was really interesting. It's not a procedure I'm familiar with. I've got a couple of questions, and I think my first one was really around which patient group you think this would be the most beneficial for. Do you think this would be something that would replace a surgical sleeve gastrectomy, or would it perhaps be applied more to patients who are wanting to lose weight for a particular other health interventions, so perhaps some cardiac surgery, orthopedic surgery, and perhaps need to have something quicker? I wasn't sure whether these patients would go through tier 3 as our surgical patients do. So I was interested to hear what you thought about the patient group that would go forward for this.
Shall I take that one? So it's a really good question, and to address some of the issues in the paper there, the South American Bariatric Society and the Saudi Bariatric Society have both lowered their lower BMI to 27.5, and so they operate on a lower threshold, as it were, than we do in Europe. That has a big bias, obviously, in the paper. To answer the second question as to who it's applicable, where this sort of sits in the bariatric world, as it were, well, the paper and lots of other studies and meta-analysis do suggest that it's got a lower complication rate, and hence the BMI range has for the ESG is predominantly between 30 and 40 BMI. Because of the lower risk of complications, you can go with a lower BMI, is the argument. And in terms of outcome data, that does seem to be where we get the best outcome from the procedure, getting a good 20% total body weight loss at about a year. In terms of the third bit of your question, which was who else might it be suitable for, there is, and it has been used as a bridging procedure, perhaps, and they've certainly used this in Germany a lot, where they've used it where patients are stuck on intensive care and they can't get them off without weight loss, and so they've gone in and operated on high-risk patients. Because again, it's a lower risk procedure, and it has enabled them not only to get off intensive care, but also to lose significant weight, and a majority haven't then gone on to need another procedure. So it sort of, because of its lower risk, you get a lower BMI profile than perhaps normal bariatric surgery, but it is also extending its use elsewhere.
Yeah, it's interesting, very interesting.
Sorry, just along those lines, we've got a question in the audience from Jim Burney saying, is there a role for combination therapy, for example, with GLP-1 agonists plus this, given that looking at the percentage weight loss figures that you presented from that paper, they are very similar to what the GLP-1 agonists are doing at the moment, but obviously this is a more definitive option.
It's almost like I primed him, isn't it? Yeah. So thank you, Jim, that's a very good question. No, because you don't get the hormonal changes, and you're doing an operation which is giving you very good weight loss, if you then add in the hormonal changes that you would see with other surgery, there is emerging evidence that with combined therapy you get weight loss very close to a gastric bypass. So there was a study out of Johns Hopkins Unit that was published, I think, last year, that demonstrated that the total body weight loss by adding in GLP-1 agonist at 5 months got to over 25% total body weight loss at a year. Significantly different from the procedure itself, just by itself.
Just interesting. So, I mean, that's amazing, given the fact that this is then more definitive in the long term. I was just going to ask, in terms of the weight regain, and looking at those figures they've got at 24 months, the rate of it seems to be in parallel to that with sleeve, maybe even less or so. But is there any longer term data in terms of that? And what do you think the mechanisms are? Is it the same as happens with the adaptation from hormonal changes?
Yeah, so it's very that Al-Qahtani paper is very interesting, because you see the weight loss. If you look at the weight loss over the 3 years, you see that the ESG and the sleeve come down together, and like other papers, the ESG is delivering 80% of the excess weight loss that a sleeve would do, and then they sort of hit the plateau at about 2 years, and then they both start coming up. But the sleeve, the formal sleeve, is coming up quicker than the ESG. Now, whether that's because it's gone down harder and it's just coming back up quicker, but they comment on it in that paper, but they don't sort of extrapolate it much more than that. There are some 4-year data that's coming out shortly, which again is good and supportive. You know, like any bariatric procedure does show some weight regain, but it's not bouncing straight back up. There's one 5-year paper that is from Cornell and in the States, and it's really good that it's there, and it does demonstrate 5-year weight loss. But it's a little weak in that there's only 1/3 of the patients are available at the 5-year mark. So it's not a really true reflection of what's going on. And I think we'll see the 5-year data coming out much more in the next couple of years.
That's great. I can't wait to hear it and see what the results are. It's really interesting, and it's just something that, for often with the novel procedures, people, you know, the initial early adopters and the data that comes out, there's always a lot of skepticism. But for the ESG, I feel like all the data that's been coming out recently has been positive, and we're still waiting. I don't know, the cynical amongst us is still waiting for the negative, but it's very promising.
Well, hopefully we'll get a bit of negative with the next one to give it a very balanced thing. But it is, you know, that's why I put that slide up initially. It's an evolving technique. The evidence is not what you would want it to be, but as it's an early procedure, that's what we get, and that's what we have to work with to then develop the evidence base more than we have already.
And I think that meta-analysis reflects that entirely. It's very typical for what you'd expect to see for an evolving procedure and what evidence there is out there, and you know, made up of retrospective studies, no randomized studies. But what it does show is that it appears to be a clinically meaningful effect, one, and from what data there is, as you say, is wouldn't see universally positive, but certainly doesn't appear to be negative. So you know, there seems to be a role for it going forward.
Fabulous, thank you. Shall we move on to the second paper?
Yep, so the second paper that we're going to discuss is titled, Does Endoscopic Sleeve Gastroplasty Stand the Test of Time? Objective assessment of endoscopic ESG appearance and its relation to weight loss in a large group of consecutive patients. So this is a paper that was published in 2019 in Surgical Endoscopy, which has an impact factor of 3.747. So it was a prospective single center, sorry, I'm just trying to go on to the next slide. So it's a prospective single-center observational study carried out by Professor Silvana Paretta's team in Strasbourg in France, which is a tertiary center performing both bariatric surgery and interventional endoscopy. And the aim of this paper was to determine the relationship between integrity of sutures and weight loss, and is the first study of its kind assessing how technical failures might affect outcome. So in terms of the patient cohort, the inclusion criteria were patients 18 to 60 years old. They had to have been morbidly obese for more than 2 years and previously failed medical treatment. They recruited 133 patients over the course of October 2016 to April 2019. So the methods that they used. So all the procedures were performed by the same surgeon, who is a bariatric surgeon who also specializes in interventional endoscopy. And they used the same equipment, which is the overstitch by Apollo endosurgery. And the technique that the author describes is that they use an interrupted U-shaped purse string suture pattern from the incisura to the fundus, sparing the fundus, as Mr. Kelly mentioned at the beginning, to induce satiety and delay gastric emptying. Each purse string suture consisted of 6 to 8 full thickness bites incorporating the anterior gastric wall, greater curve, and the posterior gastric wall, and then going backwards, completing the U shape in the opposite direction. So the average number of sutures that they used was 4, and then the patients had 6 and 12-month follow-up endoscopies, which were all carried out by the same surgeon as well. So the primary outcomes that they were looking at were suture integrity at 6 and 12 months and its relationship to weight loss. And the categories that they used to describe suture integrity was open, so where all the sutures were loose, partially intact, where at least one suture was intact, or intact, where all the sutures were present. And these are the photos that they have included. So in A, this is shortly after the procedure itself. In B, this is intact. C, partially intact, and D is open. So the secondary outcomes that they looked at was the impact of the patient's initial BMI on longevity of the gastroplasty, the rate of suture disruption over time, and to assess role of the learning curve of the operator in the first year. So in terms of the results, so at 6 months follow-up, there were 87 patients. And the first thing to note is that the majority of these were either partially intact or intact. And this correlated with a greater percentage of excess weight loss and total weight loss. And this is statistically significant. They also noticed that patients with initial BMI of less than 40 were much more likely to have intact sutures and to have greater excess weight loss percentage, which was also statistically significant. And in addition, patient age also had a significant effect on excess weight loss percentage, in that the younger patients had a greater percentage weight loss, although this was not correlated with suture integrity. At 12 months, there were 41 patients who were followed up, and some were lost to follow-up, and some were excluded for medical reasons. So more than 80% of the patients at 12 months follow-up had intact or partially intact gastroplasties, and there was still a correlation between suture status and excess weight loss percentage. However, this did not reach statistical significance at 12 months, possibly due to the small population sample at this point. What they did notice was that there was a statistically significant impact of the learning curve, in that in the patients who had their procedure in the 4th quartile, there was a much greater percentage of intact sutures at 12 months than when compared to the patients who had the procedures in the 1st quartile. And this is a graph that shows that. So as you can see, so the blue is open gastroplasties, and this reduced over the number of procedures that the operator did, and there was an increase in the number of intact gastroplasties at follow-up, and this was statistically significant. The author comments that this is probably explained by the quality and aggressiveness of sutures increasing with experience. So from the author, the take-home messages were that full thickness bites are key to reach success in these procedures. Particular attention needs to be paid to the stitch at the level of the incisura, as this is the one that was seen most commonly to be loose at follow-up. Suture patterns don't seem to be a predictor of the results, and suture stability does influence total body weight loss percentage over time. So the strengths of this study, it's the first study of its kind. They had clearly indicated primary and secondary outcome measures, and they had a very clear and specific methodology. There was a consistent and detailed primary technique, as well as consistent and detailed endoscopic follow-up. Some weaknesses of the study, it's a relatively small cohort with a short follow-up, so follow-up was 12 months. All the procedures were carried out by a single surgeon at a single center. At 12 months follow-up, there were less than 50% of the initial patient cohort. There's a lack of control group, and as with all of these, longer term follow-up is required. So in terms of summarizing the evidence, the main points from this study is that the more sutures that are intact, the higher excess weight loss percentage achieved. And the sutures are more likely to be intact in patients who are younger and with an initial BMI of less than 40. And also if the operator has done more than 40 procedures. In terms of a technical perspective, having discussed this paper briefly with Mr. Kelly earlier, there possibly needs to be in future studies, possibly needs to be greater standardization of the technique used, as the average number of sutures used by the author here was 4, as we mentioned. However, I believe that possibly the number of sutures used in practice over here tends to be greater than that. And possibly in terms of the volume reduction of the stomach itself, there might be some variations in terms of their practice and our practice over here. So in terms of implications of this study and the previous paper, ultimately from both studies, both studies have shown that ESG does work. It achieves clinically meaningful weight loss, and it seems to have a good safety profile. As Mr. Kelly mentioned, it preserves anatomy, it leaves future surgical options open. And in terms of for it to be a successful procedure, the important factors would include patient selection and the operator learning curve. And further studies in the future are more likely to produce better results once there is more experience in the field of this procedure. Thank you.
Fab, thank you. Another really interesting paper. I'm curious to know, we discussed that we could go on to performing further bariatric surgery in the future, but actually if you found that some sutures weren't intact on check endoscopy, can you revise the endoscopic procedure?
Yeah, there's good data out of Spain, out of Madrid now on that. And there seems to be certain cohorts who respond very well, and certainly those who, from Lopez Nava's data in Madrid, what you mustn't do is reoperate on people who don't do well initially, because they're not going to do well again, and they're probably not going to do well whatever procedure you give them, and it might be more appropriate for them to spend more time with the dietetic psychologists than anything else. But there does seem to be good outcome data if patients sort of plateau at about the year mark, and they've initially done well and they want more, and Gontran went back in them, and they then lost a good more amount. I think it was around another 12% total body weight loss, something quite remarkable. And then he also did a group that were, I think, 2 years down the line, and again, who had plateaued at that point. And they lost, I think, in the region of another 8% of their total body weight loss. So again, they did well. And I know it's only an example, but one of my patients had 4 very good years out of her ESG, and then went into lockdown, and as she described, just blew everything to bits with the stress and anxiety. And she came back to me, and I thought she was going to come back and say, "Can I have something else?" But she said, "No, I just want I want the ESG back. It works for me, and it's great." And so I've redone that for her 5 years after the original procedure, and she's 6 months down the line, and her BMI is 25. So, you know, it does. Yes, you can get it. You preserve all your body, as it were. You don't lose anything. You don't have the B12 deficiencies. You don't get the reflux, and it can be redone. But this last paper is really brave. I think it's brave anyway, because it's somebody publishing their data during their learning curve, which you really rarely see. And I think it's a very brave paper to have done. And I think there's lots and lots of little details in there that are really useful to us. You know, for example, the fact that age doesn't matter. And in actual fact, the younger the patient did, slightly better. And with my experience, the younger patients are less compliant with dietary advice and often do worse with bariatric surgery. You know, it's as they say, the distal sutures cut through and pulled out more than the proximal sutures. Should we modify the technique around that? It is weak in that it doesn't conform. Their ESG doesn't conform to most ESGs around the world, and they, you know, the 4 stitches is you know, not many. And you know, I think the Mayo Clinic would, on average, you know, certainly in their initial series, were putting more than 20 sutures in. So very different in terms of, you know, the effect, but a really useful paper to demonstrate a learning curve and to publish that in a learning curve.
Yeah, definitely. Well, I think this has inspired quite a few people. I've got 3 questions have popped up on the panel, so I'll put those to you if that's all right. So the first one from Andrew Wan is remission of diabetes over a longer period, is it similar for both procedures? So between the laparoscopic and the endoscopic?
So because of the better weight loss with other procedures, they see better weight loss. But Andrew, there's a really interesting bit of data hanging out there that although you don't get the gut hormonal changes, there is a sort of odd response to diabetes, i.e. they get a quicker remission of diabetes than might be expected. And it's thought to be mediated through the stretch receptors and the effect that they have on the pancreas. And I understand that the group that published that are doing a bit more work on that at the moment.
Thank you. James Byrne would like to know, if the learning curve is 40 procedures, how do you think we should get operators to that level of competence required to not subject patients to the operator learning curve?
Yeah, I think that's a super question, and it's really difficult. And I think that's where it is important to be proctored in the initial phases. It just, because even now I'm still learning how to do the procedure, and I learn on every case. But I think there does have to be proctoring initially in order to protect the patients to minimize that learning curve. And that's why I think Apollo very sensibly sort of run courses and, you know, run labs on how to use the device and how to get the best out of the device, so that you go in prepared and then you're proctored for the first cases. And I think that is important.
Yeah. Can you do cadaver training for the
Oh, I'm
procedure?
glad you asked that question, because our next course is yeah, no, we do run a course, and I think the next course is in March or April, where we use pig stomachs actually, and train on pig stomachs.
Okay. Kashif Halim asks, do you do any routine pre-op esophageal pH manometry testing?
No, haven't done that. I'm pretty sure, I don't know if Zach has got it, there is a paper with pH monitoring, I think has been published this year, but I can't recall the details of it, but there is one out there. What is in this paper, which hasn't been brought out, there's loads in this paper, it's really subtle, but it's there, is when they did the endoscopies, the follow-up endoscopies, they also assessed the esophagus for esophagitis, and I think it went from a starting point, or grade A or a grade A or above esophagitis. It started at, I think, 15% and went down to, I think, 1.8% at 1 year, or something like that. So there was macroscopic evidence of reduced gastroesophageal reflux during that time frame.
That's
You've got
great.
quite a few panel questions tonight.
Yeah, so I've just got a couple of questions hopefully to tie us through. In clinical practice, the paper was talking about surveillance endoscopies looking at the stitches, but in clinical practice, is that something that you would recommend? Do you do follow-up surveillance endoscopies, or only if there, or what would be the indications to do one if not?
No, so really try and avoid that, because it's like it would just lead to significant disappointment potentially, and what you'll see, and there is some work around, I think the Mayo have done some work around this, is that even if you get stitch disruption, you still have scarring from the procedure that leads to delayed gastric emptying, and so you still get the effect of the procedure, although it might be lessened. And so they still feel satiety, and they still feel and they still get delayed gastric emptying. So it's like if you routinely endoscoped a bypass, you gradually see the gastrojejunal anastomosis widen, and the patients would be upset, and you'd see perhaps the pouch would get bigger, etc. And so should we do that in this procedure? No, we shouldn't. We should treat it like the other procedures. If it's still effective and it's still working, then you don't need to investigate it.
Sure. And are there any instances then when you would surgically revise it, for example? What would the indications be? I was just trying to think in terms of, you were saying that you redid in terms of the endoscopic one.
No, you can. I smile because it's the patient, and it's been done around the world, but the patients often come back and they just put their hand up and said, "Look, I'm really sorry. I didn't listen. I just didn't appreciate how this worked." And it's a very small percentage. It's it's less than 2% in the literature. But they do come back and they say, please can I have something else, and you can revise them to anything else you want them to, or whatever they want as well.
Well, thank you. I've just seen at the time we've got a couple of minutes to close. I don't know if you've got any closing remarks, or Zach, if there's anything more changing.
No, just thank you very much to everybody, to our sponsors, and to the hard work from Zach and Chen there to putting all of that together. Thank you all very much, and thank you all very much for your attendance and listening.
Yeah, wonderful, and thank you everyone for joining us tonight, and thank you to the Southampton team. It has been incredibly interesting, and now I'm kind of thinking about how we can all get endoscopic training into our surgical curriculum so that we can.
Oh, that actually, that is a really
good
point. That is a really you can draw that conclusion at the end, is that from a trainee point of view, the gastroenterologists are trying to almost lock us out. And we see in Europe that surgeons have been locked out of gastroscopies. Certainly the upper GI surgeons have, in the form that they're no longer remunerated for it, and so that they can't do it any longer. And I think that is problematic, because we are seeing the emergence one way or another with POEM, with ESD, and endoscopic anti-reflux surgery. There is this evolving area which should be, I strongly feel, should be done by sort of a surgeon and a gastroenterologist sort of mixing and maxing, sort of helping each other's skills rather than territorially marking it out. And actually, that's not the right thing. We should be working together rather than siloing each other.
And interestingly, there's some questions from trainee members in the audience as well, senior trainees, Vasha and Michael Glacier, who are also asking similarly that this should be part of our curriculum and who's best to deliver this. So exactly what you've just described.
Yeah.
Thank you very much, everybody. I don't want to keep you, it's 8:45. If we don't, well, we'll hopefully see you all next week for the BOMSS educational webinar next Wednesday. But if not, then have a happy Christmas and happy holidays, and we'll see you in the new year. Thank you very much, everybody. Good evening.
Thank you.